So, welcome. Welcome to Medical Mondays with Dr. O. And I'm trying to get all of these things off my screen. Yeah. I think I successfully got them off. Good evening, everyone, and welcome to Medical Mondays with Dr. O. I am Dr. Toyin Okwesami, a family practitioner, HIV specialist who also treats addiction in Maryland. I enjoy coming here every Monday at 7 p.m. just to learn from specialists and also to share knowledge that I have. This forum has been an amazing one for us, where we have learned so much in bettering ourselves and also preventing disease entities that can otherwise devastate. Tonight, we have one of our best, one of our amazing physicians in the DMV area. It is my honor to introduce to you all my brother, my friend, and as I said, an amazing physician who is, as you have seen in the invitation that I sent to you, a consultant endovascular and vascular surgeon, chairman of surgery at Raleigh General Hospital, Berkeley, West Virginia, also surgeon, endovascular consultant at the West Virginia Vascular Institute in Berkeley. He's going to talk to us tonight about knowing the vascular problems that can kill. As we say all the time on Medical Mondays with Dr. O, prevention is better than cure. And he's going to help us with that. He's also going to talk about subarachnoid hemorrhage. It's part of it, the vascular issues, which some of our Medical Mondays family with Dr. O has been asking for. So without much ado, I'm going to yield the forum to our very own Dr. Herbert Oye. Dr. Oye, the floor is yours and welcome.
Thank you, Dr. O. Good evening, Ms. Chair Lady, and members, and in person and via the virtual platform. I'd like to say thank you for the invitation. It's indeed a great pleasure of mine. I have chosen the topic this evening because I can talk forever about vascular surgery, of course, but I want to put it in context and on the as captioned, prevention is better than cure. Knowing the vascular problems that can kill you, it's a problem. Let me say that as a vascular surgeon, I started my practice in 1997, and after training at the Arizona Heart Institute and training in New York, I decided to come to rural West Virginia, where there was no, at that time, not major vascular programs in terms of, because of its rural nature. So I came to communities here and started endovascular programs here. And over the year, time space, I've started about maybe 5 or 6 here, and also then moved on to Nigeria and started 1 and maybe 4 programs now in Nigeria. So it's passion. It's something that I'm passionate about, vascular surgery. And today I'd like to talk about the fundamental things that patients should know, healthcare providers should know, that would save the patient's lives, and in so doing, we'll be able to ensure that we advance vascular surgery in the way it's meant to be. Let's go to the next slide, please. My slide's been shared with me by my medical student, Dr. Abu Aruna. He's in Texas, so he'll be forwarding the slide. Abu, next slide, please. Next slide, please, Abu. What are the vascular problems? What are vascular problems? Vascular problems indeed are problems that that are blood flow related conditions that can cause issues with circulation. Importantly, if you look at the human anatomy, what are the things that will kill us? The things that will kill us are very simple. Take away cancer, take away the malaria in third world countries and cholera, dysentery. Every other disease profile in the Western world is now common in the third world. Lack of blood flow to the heart attack. You'd hear people having heart attack and having stents in their heart. That is because there's a blockage of flow to the heart. In some other parts of the world, they don't have the luxury of having stents put in, so they just die. Lack of blood flow to the brain, strokes. If you have a stroke in the United States, as debilitating as it may be, we do have options. We can be treated swiftly within a 3-hour window or so. You can have special medicines that will wipe out the clot in your brain and restore flow to your brain, and you feel better. You may have bleeding in the brain, like Dr. Ho said, and you could have surgical intervention by a neurosurgeon to remove the bleeding spot, and you feel better. You can have lack of blood flow to the intestines, which is very dangerous, what we call ischemia, that will cause you abdominal pain and eventual gangrene of the intestines, and that may result in death. Lack of blood flow to the upper and lower extremities is very common. You have constant pain, especially in the lower extremities where you have wounds that don't heal, and eventually may advance to gangrene or even death. Again, one of the factors that is a silent killer in America and also worldwide is a condition called aneurysms, where we have ruptured aneurysms, where the arteries in the abdomen could be in the abdomen, could be in the brain, but usually the one that really is more of instantaneous deaths in the abdomen, where the artery gets to a certain size and it just ruptures. It's like a balloon at Christmas time or a party. You inflate the balloon, the pressure increases, and at a certain point, the pressure is too much and the balloon bursts. It's the same concept when it comes to aneurysms. So we all have the big artery in the belly, the aorta, that leads to heart. From age 20, if we're going to develop aneurysms from atherosclerotic disease, the artery wall starts to get weak. As that gets weaker in our 20s and 30s and 40s, around our 50s, that artery may get to the size in women about 5 centimeters, about 2.5 inches, and in men about 5.5. And at that critical pressure, when that critical pressure does reach, that artery can burst. If it's that person has an artery that bursts at home or on the freeway and they're not close to the hospital, it could be imminent death within minutes. We're talking minutes to hours, depending on how big the hole or rent is. So aneurysm that ruptures could result in instant death, and ruptured aneurysms are nothing to play with. They're silent killers. Most people that have aneurysms don't know they have it. They don't have any pain. The only time they have pain is when there's a rupture, or they're having pain because the aneurysm's getting larger, so it presses around the surrounding organs, and they have discomfort, or they're doing a test that's totally unrelated to the aneurysm, a CAT scan for something else, or an X-ray for something else, and the image of the aneurysm shows. We know in America, we have a polarized Congress. Even the Democrats and Republicans don't agree on anything nowadays. But in 2006, 2007, as divided as we were, they agreed on what we call the SAVE Act, SAAVE. That's where any person who is age 65 or greater, if they've never had an ultrasound of the abdomen done before to exclude an aneurysm, they can get a free test, free ultrasound, and that is to save lives. So that's something we have to commend Congress for taking that bold step in 2006, 2005. Next slide, please, Abu. Other conditions that we need to worry about and would be prevention that far outweighs the cost of curing complications when they do occur. And yearly physical examinations are important when you visit your primary care physicians. Early detection by a provider of a vascular condition and appropriate intervention, if needed, can save your life. again, for just like we take immunizations and vaccinations and stay healthy, it's important that we look at our vascular health in that way. We should strive for optimal control of our blood pressure, for optimal control of our blood sugar. One of the things that we must know for persons who have hypertension, if you take 5 persons now in the United States, 3 of them will have high blood pressure. And the risks associated with high blood pressure include get heart attacks, get strokes, get ruptured aneurysm does occur with uncontrolled high blood pressure. And kidney disease is another problem that we can get from high blood pressure. And next slide, please. And in diagnosing vascular problems, it's not magic. It's not rocket science. Your physician or you, the patient, can understand your history. You know who you are. When you wake up in the morning, you know when your body feels good, when it doesn't feel good. Now, if you have a circulation problem, you would know, because there are some things that you must know if you have a circulation problem that's causing you discomfort. What we'll call the 5 Ps. You have pain, you have pallor, the limb gets pale. You have pulselessness, you don't have a pulse. Your leg is cold, poikilothermia, and you have paralysis or paresthesia. Those are the things that will tell you that you have a problem ongoing that you've not had before. Let's assume that every person in this forum now is healthy tonight, and you go home and by 2 o'clock in the morning, you wake up with a painful right leg, for example. It's cold and it's just painful, and it looks pale, and you're able to check your pulse. You don't have a pulse. That means at that moment in time, you have what we call an acute arterial problem. That means you may have thrown a blood clot to your leg that has interrupted blood flow to your leg, and that's why you're having that pain. So your ability to recognize you have a problem and your ability to now seek help that early in the course could potentially save your life and save your limb. So it's very important for you to seek help when you think something's not quite right. When you go to your PCP or your primary care physician or your specialist, they have to examine you. Before they examine you, they're supposed to get a little history about you. And it's important that you give them pertinent history. Don't hold anything back. Tell them what they need to know so they can come to a good diagnosis or reasonable diagnosis that will fit your condition in question. And as part of the testing, when it comes to vascular surgery, just like you check your blood pressure, there's a test called the ankle brachial index, the ABI. That's extremely important. If you have an ABI that's 1.0 to 1.2, meaning 100% to 120%, that means your circulation is perfect. That means you're not going to lose your leg, okay, unless you're diabetic and unless you have an infected wound for some other reason. Even though your circulation is okay, you can still lose a leg. But if you have an arterial-based problem, you suspect an arterial-based problem in a patient, or a patient comes to you with a leg pain complaint, and the ABI is 1.0 to 1.1, 1.2, they have normal arteries. You got to figure out another reason why they're having that pain. In the grand scheme of events, if somebody has leg pain, you have the most important item is the arterial circulation. Does the person have normal arteries or normal arterial flow? The ABI is that tool, simple, cost-effective tool. It's just checking the blood pressure of the arm and the ankle and Gulner ratio, and tells us that it's 1.0 or greater. That's normal. If the person comes that you were examining and shows up and the ABI is 0.3, they have a problem. They have a severe problem. So somebody who comes to ABI of 0.3 and were normal 24 hours ago, and the ABI at this moment 0.3 or 30%, they have a new onset problem. So the physician seeing the patient, the nurse practitioner, the physician assistant must understand almost immediately that that's an emergency. They can't say, oh, come back next week, come back 2 weeks, I'll send you to a vascular doctor. It's a bad idea. That patient will lose their limb. So if that same patient, on the other hand, has an ABF 0.3, but they've been having pain in that leg for the past 1 year, 1.5 years, that is not an acute event anymore. It's a chronic problem. So they may have an ABF 0.3 and still function. And I do have patients with ABF 0.3 that walking around, functional well, because number one, they're elderly. Number two, they have developed what we call collateral circulation because it just didn't happen overnight. What happens is nature's kind. If we have a plaque buildup in our arteries, and if I have to drive, say, from here, West Virginia to Maryland, and have to use the highway, and for any reason the highway gets clogged up, there's a major accident, people will now start finding a feeder way to go around that artery. That's the collateral circulation that nature normally provides. Dormant arteries now become very prominent with time. And that's more that you see that in persons that are much more elderly. You would not see collateral circulation that's that prominent in a young 30-year-old or 20-year-old, but somebody who is 50, 60, 70, 80, they've been having pain in the leg for a long time, the artery's been slowly clogging up, they will start to develop the collateral circulation. And the next thing your doctor would decide is whether or not your leg pain or your vascular problem requires an x-ray. Sometimes you might have broken bones that may be as a result of your poor circulation. Sometimes they may decide to do what we'll call a venous ultrasound if there's a suggestion that the problem you have is a vein problem. They could do an arterial ultrasound if they want to find where the blockage may be in the leg or in the arm. Again, another testing that we sometimes do is called a CT angiogram. It's a dye test. We inject the arteries. We're able to specifically identify the arteries that are involved, so we can now plan treatment and or MRI again would be another test. When we say we plan treatment, treatment is varied. The initial treatment for most vascular patients, if they are stable, is medical treatment. So that's why we talk about prevention, prevention, prevention. And if we do the right things, we eat the right foods, we're active, we're not sedentary, we don't smoke as much, we minimize our risk factors, then we can be managed medically with and do fairly well. But when we start to get that point where medical therapy and preventative health is not helping us enough, sometimes we have to look at the curative option. And when it comes to curative option, the intervention therapy could be, if it's the heart, the cardiologist may have to do some type of work to improve blood flow to the heart. If it's the radiologist may do some fluid intervention to improve blood flow to the kidneys, and the vascular surgeon can do that too. But specifically, endovascular surgery, my area of specialty or subspecialty, is minimally invasive surgery that we entertain or use to improve circulation once the problem is identified. Next slide, please. So treatment options. It's important that we talk about lifestyle modifications, okay? Again, not smoking, maintaining a good weight, not being overweight, obese, and doing the right thing, exercising. Those are things that we can help make our lifestyle better or our health better. When we get ill, we then start medical therapy option. Then we can move that to endovascular therapy. Then we can move that to hybrid procedures and ultimately to surgical intervention that's a lot more invasive. When we talk about vein surgery aspect, we are same concept. We do compression therapy for people who have varicose vein issues, and then we'll then end up with sclerotherapy and sometimes laser therapy and sometimes surgical intervention to remove veins. Next, please. So endovascular procedures. What are endovascular procedures? These are minimally invasive procedures that are performed to improve blood flow, and we use special tools to do this. And this does require balloon, wires, catheters, stents to ensure that the area in question that has limited blood flow can have improved blood flow. At the end of it, we can put stents, we can remove blood clots, embolization, if there's embolectomy, if there's a blood clot issue. If you have an area of aneurysm and artery, we sometimes can embolize it, close that area with either coils or sometimes with stents. Next, please. The endovascular surgery as a surgical field in itself has been ongoing for the past 35 to 40 years. It's rapidly expanding. We have tremendous amount of technology that's cutting edge technology that's developed over many years, to the point that vascular surgery in the early 90s, which at that time you had something to be done, someone had to open you up, you had to do a bypass. Nowadays we can achieve most of this interventions by not making any cuts at all. 90% of the time we can do them with endovascular technology, and that's the beauty of it. So we don't want to do surgery such as this if we take the preventative steps. But if we don't take the preventative steps, at some point we'll need surgery. And when we need surgery, we want to try the minimally invasive options first before we go to the more major open surgeries. Same thing goes for open heart surgery. You put stents in the hearts first, and if those don't work, the patient doesn't qualify before they get open heart. Leg bypass surgeries and big abdominal surgeries, the same concept. Next slide, please. This is just a schematic diagram showing the arteries of the leg. If you look at the lower picture below the knee, you would see that there are three branches of the artery. The one that's on top of the ankle is anterior dorsalis pedis, and one in the medial aspect is the posterior tibial. Anytime you have a leg problem, put your finger around those areas. You should be, if you feel a pulse, you're good. If you don't feel a pulse, you got a problem. But sometimes feeling with your fingers may be deceiving if you have circulation problem. So we have a tool called handheld Doppler that we actually use to hear the signals to give us a good sense that we truly do have flow. So in the office setting, your clinician should be able to use a handheld Doppler to hear the signal, so they're not feeling their own pulse and telling you they have a pulse when you don't. And the top picture left shows the carotid artery. These are arteries that if you have a blockage in the neck, you sometimes can throw a clot or a plaque that can go to the brain and cause you on to get a stroke. Nowadays in America and other parts of the world, we sometimes, over the past 50, 60 years, where we can go in and make a small cut, take a plaque out, restore flow. If there's no bleeding involved in the brain, well, if it's just a blood clot issue. Now, there are newer techniques nowadays that sometimes for certain patients who have bad hearts, bad lungs, have high-risk surgery patients nowadays, we can put special stents in the carotid artery, at the same time reversing the blood flow to the brain so they don't get a stroke. It's called TCAR, capital TCAR. So that's a newer technique that's out that for the past 3 or 4 years that we're also doing. And the schematic on over here again shows you the blood flow to the head, blood flow to the arms, blood flow to the heart. The heart's a major organ. What happens for the heart? A blood clot can leave the heart, and it can go anywhere when it leaves. It can go to your brain, cause you a stroke. It can go to your arms and immediately get a cold hand and painful hand, and you'll need a vascular surgeon to come in and take the clot out and restore flow to your hand. It can go to your intestines and cause you to have gangrene and intense abdominal pain. It can go to your legs and close the arteries to your leg, and as you'll see shortly, and you have severe pain in that leg. So that's what the blue is the vein, the red's the artery. Next, please. So this is an example of a patient who is a smoker. As you can see, the two fingers are dark. And that's a condition called Buerger's disease, common in smokers, more in females than men. And the treatments usually stop smoking and they'll feel better. Now, in intense cases like this, we sometimes go and stick a needle in the artery and put some nitroglycerin in the artery to help expand the arteries. And sometimes that helps. But that's Buerger's disease, thromboangiitis obliterans. Next, please. This is a bad wound we see here in America. We see similar wounds around the world, in Africa. There, people show up very late in the course. and they show up with something like this. And sometimes you're lucky, you're able to help them. Sometimes you're not. Again, remember, in America, perivascular disease affects over 12 million Americans. We have over 200 amputations a year in the United States. And the patients like this can easily get amputations. Now, there are two types of vascular surgeons. There are one group of vascular surgeons, the older version of vascular surgeons. They see your leg, they take a look at it, they give you an amputation. That's it, no discussion. And you have a second group of vascular surgeons now that believe in limb preservation. So they see your leg, it's bad. What can we do to improve the circulation? Let's clean the wound. Let's do what we can do to save your leg. So that's what it is. I belong to the second group of surgeons. We believe in limb preservation when possible, because the psychological issues that are involved when you lose a limb are tremendous. Work-wise, emotionally, family-wise. Before you advise amputation, and the family doctor should also know that. Your PCP should also know this, before you advise amputation to the patient, you have to make sure the patient's psychologically ready. Because if you just say, oh, Mrs. Jones, you have this leg problem now, amputation, they'll get depressed. Mr. and Mrs. Jones you may do a successful surgery, but they may die from the depression of losing a limb. So they have to come to terms that, yes, nothing else can be done. And now they have to get the limb cut up. But you have to reassure them that within 6 weeks from the day of surgery, they should be able to walk again. Because in America, we have ways we can get prosthesis, they can walk away and walk better than the way they were before the surgery was done, if they have to get an amputation. So we have to be able to give them time to absorb the fact that they may lose a limb, and the fact that time that, so they don't get too depressed. So that's very important to know. Next step. So let me give you a few examples of gentlemen here. This is a guy who called it ischemic leg. This is a painful leg that has no blood circulation of significance. This fellow came to me from New Hampshire. And when he came, he had surgery in New Hampshire. And the doctor in New Hampshire put in stents. If you look closely on the left slide, you can see the stents there. That's the knee joint. And you can see there's an overlap between the top stent and second stent, and there was a clot right there. There was no flow going through. So I was able to manipulate a catheter device through the blockage. And once the catheter went through the block in the second slide, we were then able to eventually make wires go through it. We'll put some clot busting medication. We're able to suck the clot out, and we're able to restore flow for this gentleman. And he's doing well now. Next slide, please. So that's the restoration of flow through the stents. And you can see flow below the knee. You can see the balloon angioplasty down on the left screen. Next, please. And that's him again. Next, please. Next slide, please. This is a typical diabetic foot wound. And this screen here shows a patient with iliac artery occlusion that needed angioplasty and stenting, and patient did well. Again, you could see the blockage on the left. We're able to enter what put wires through and balloon and restart flow. Next. Next up. You see the balloon angioplasty being done right now to restore flow, the two wires in the aorta and the iliac arteries. Next. I think we have a delay because I was in Texas. Next. Abu, you there?
It changed the slide. Oh,
I changed already. I changed this.
it changed the slide. Yeah, we saw the resolution of the occlusion.
Okay, very well. So now the case, I traveled to Nigeria, and this is a patient of mine. He had what's called a femoral anterior tibial bypass. And I got back, and he came with this. And the doctor was covering for me. He had to say, but I want to do an amputation. I said, no, well, maybe we can still save his leg. So I took this guy to surgery, and he already has one amputation, one limb. So he's trying hard not to lose his limb, and we're able to take him to surgery. Next slide, please. We're able to identify flow. Next. Next. And that's the leg after it was treated. We're able to restore flow. Next, please. Next, this is a patient with diabetic foot ulcer, common in West Virginia, like I'm pretty sure like Maryland too. Next. This typical arteries you would see. Somebody special has lost a limb already in one leg, and they have significant disease on the right leg. And you could see the collateral circulation in this person, generous collaterals. Next. This is a technique I use for sometimes when we can't get to the artery from above using endovascular means, we sometimes use what we call hybrid technique. Rather than do a bypass, we'll sometimes can go from the knee area and go up retrograde, and we're able to make a wire go through a complete clogged artery and restore flow with balloon angioplasty. It's a new technique that we use called intravascular lithotripsy, and helps remodel the plaque and prevent us from doing a bypass. So this is what I did on this patient. Next. This patient here, you can see left leg problem, a week, present a week after the incident. And we were able to balloon the area and put stents, which you see on the right side, and restore flow. Next slide, please. You can see the stented area. The right looks pretty good. The left has the stents now. Next. And this patient I did see in Nigeria about 12 weeks, maybe 12 weeks ago, maybe 14 weeks ago. Traveled from Benin to Port Harcourt with an ischemic leg, and she was treated. That was the night before I had to leave. I stayed up from 1 o'clock, 12 o'clock, 12 to 1 o'clock, 2 o'clock, fixed the leg. And now the good news is she did not have to lose a leg. Leg's much better, foot's much better, and that's healing nicely. Next. Some things that we see in the US, you can also see that in Africa. Next. Typical diabetic foot wound. Next. This where simple case of angioplasty, blocked artery on the left. You could see it, and you can see the blockage right there, and treated with balloon angioplasty on the right, and with resolution of the area in question, simple treatment. Next. So minimally invasive, no cuts involved in this case. Next. So again, this is a case of embolectomy. This patient had blood clot in the artery. And you can look on the left side, right above the knee, you could see the missing portion. Simply, we just stuck the left side of his groin, what came from the left to the right side, and used the penumbral catheter to suck the clot out and restore his flow, and his blue toes got better. Next. Next, please. This is the lady that had aorta, was stenotic, and were able to do angioplasty. Because in the previous picture, angioplasty and restored flow, and stented it. Next, please. Again, the fundamental things that we have to worry about when it comes to prevention prevention as a means to help improve our vascular problems, it's important to first of all identify if we have an arterial problem, a venous problem, a lymphatic problem, a nervous problem. Because if one has leg pain, again, it's not rocket science. You have an arterial problem, which make you lose your leg if it's not taken care of. It could be a venous problem, which typically does not make you lose your leg unless it's really badly infected. It could be a back problem from back problem coming from sciatic nerve. It could be a problem from arthritis. It could be a problem from lymphatics. So it's important that you discriminate one after the other to kind of get the root cause of it. You may be surprised as to how many physicians in the US, in our emergency room, that will send a patient home with obviously acute ischemic leg and tell them they have sciatica. That's a no-no. Because if somebody comes to you and you've seen that person, they have pain in the leg, and you've done the ABIs and the ABI is normal, then we could say sciatica. But if you've not done the ABIs and you've not checked their pulses and you say sciatica and it's not sciatica, they trust you as a doctor, they go home, they come back a week or two later with a dead foot. That's a lawsuit. So it's very important that you understand that you have to check the pulses with a handheld Doppler, not even your fingers, because your fingers may deceive you and tell you have a pulse when you're actually feeling your own pulse in somebody who's pulseless. So it's important for us to know that. Endovascular surgery is a wonderful tool for us to treat patients. And we do it routinely when needed, but we still think prevention is better than cure. And if we prevent and do our yearly medical examinations, we'll have a better way to prevent bad disease issues. Good health is wealth. And so we take measures to control our destiny, seek medical attention early so we do not become a statistic or a victim of our inaction. So on behalf of the platform, Dr. O, I'd like to stop at this point and entertain questions. Thank you.
Thank you very much. Oh, wow. I was clapping all through that. Thank you for being that second set of physicians, the newer generation physicians who believe in saving the limb than, just chopping it off. So, and thank you so much. A very, very able medical resident, right? Is he a resident or a medical student?
Fourth year student, medical student.
Fourth year medical student. Thank you. Coming up, Dr. Abu Aruna, for sharing the slides all the way from Texas. We appreciate you. Please, if you now put it down, you can pull the slides off because we won't bother Dr. Oye with them anymore. Thank you so much. God bless you. So, Dr. Oye, I want to get something straight. I learned last week that in all my diabetic patients that I need to be getting ultrasound to check the liver. That's new, it's standard. So now 65 and up, we should get ultrasound, the abdominal ultrasound, right? To check for aortic abdominal aneurysm.
Correct. Yeah, it's free at age 65. It's supposed to be free for them as a screening test.
Okay.
It's male or female, doesn't really matter. Again, so age 65, it's their right. They can get it. They shouldn't be charged for it.
Fantastic. Yeah. So brain aneurysm, though.
Yes.
We have no way of screening until a patient presents. And I'll tell you, we've seen quite a few of us in the Nigerian, or let me say African populace that have died from brain aneurysm or are now devastated as sequela from brain aneurysm. What's your suggestion or what's your take on that in early diagnosis?
Yes, like anything else, usually there's some precursor before you get aneurysm in the brain. Even at that, you get a headache. So don't take anything lightly. If you have a headache or your visual problems that you don't normally have, don't take it lightly. Have it checked out. Simple CAT scan will show you an aneurysm in the brain and save one's life. Again, keeping the blood pressure reasonably low or normal, it's a key. When you have aneurysms, like anything else, the law of Laplace, the higher the pressure, the higher likelihood the aneurysm will grow. Aneurysms typically grow very slowly, even in the brain. So they grow very slowly. If we keep our pressures low, then chances of that aneurysm will be small, will not grow faster, will be good. But if our pressures are in 190s, 200, then we're inviting the possibility that we could have a rupture much sooner. Again, famous person have died from abdominal aortic aneurysm, for example, Albert Einstein, he had a ruptured aneurysm, So it does happen when your pressure is uncontrolled and you smoke. Smoking is another factor that will make an aneurysm rupture sooner rather than later. So that decreasing smoking is also helpful. If I have no aneurysm, you want to avoid smoking. Keep your pressure under control. But typically headaches, and if there's a family history of aneurysms, okay, if dad and mom have an aneurysm, we have a 35% chance of having it. So if you have family members died of brain aneurysm or a friend, they may want to have their children checked, when they get close to that age, because they would most likely get it, to 30 to 35% chance.
Thank you. You did say in the slides too, I saw tetanus injection. You're referring to when one has a wound?
Oh, yes.
I saw that.
That's preventative action. Okay, when we get, just like we take our tetanus shots as a preventative measure, we should take our health, generally speaking, vascular health in that manner. We should do the right things, eat right, don't smoke, exercise, and see your primary care physician, get your yearly examination. So all those things are checked. Again, most persons that have these events typically don't check themselves. Again, in our community, we typically, wait and wait and wait and wait. And it's sometimes, it is what it is. But, if we make it a habit, remember most major vascular problems would not occur in the general population until you're around 50 and above. Okay, so less than 50, you still have a leeway, except if you have a strong family history. If one has a strong family history of heart disease, or strong family history of abdominal aortic aneurysm rupture, mother had it, father had it, and it ruptured at age 50, I don't want to wait until I'm 50 to check it. At 40, you'd be checking just to make sure you don't have it. If you don't have an aneurysm, for example, at age 50, chances are you're not going to get it for the rest of your life, because it starts in their 20s, matures in their 50s or 70s. So those are the ways we can look at it.
Fantastic. Thank you so much for that bit of history, because that is very important. So I just want to say at this point that, Dr. Oye has presented to us and we have learned a lot, but we're not establishing doctor-patient relationship. This is a forum where we're just disseminating congent, correct medical information to help, to prevent, and just to have better health, to help us thrive and do well. I also want to say a big, give a big shout to our folks from London. We have quite a few people tonight, Dr. Oye, from London. If you know, the time is now, after 1 or so in the morning. And from Nigeria also. I see Rafiu on there. I see my brother, Samuel Togun, Pastor and Minister Samuel Togun, Ayo Akintokun, Fred Olayinka, and some others from the UK. So just want to shout out, and everybody from the US, I'm shouting out to you too.
Nigeria is a complex situation. I was in Nigeria 6 weeks ago, and I had an unfortunate situation. I got to Lagos, went to Abuja, had a consultation with a fellow in Abuja, and I had an ischemic leg. Again, you at minimum, when you do endovascular vascular surgery, you need what we call a C-arm to see what you're doing. None was readily available. We had to go to Kefi to get it done. Got to Kefi and the machine wasn't working. So you have to do work. Then I left, treated him, went to Port Harcourt and Bayelsa, and then they had a problem. Do you know that in order for him to come back to meet me in Bayelsa and Port Harcourt, they closed the entire airport in Abuja. The guy could not fly out. He had to travel by train and miss the train. He had to drive. By the time he came back 24, and that's why time is critical. By the time he came back 24 hours later, the leg was too bad. I still tried to save his leg, but unfortunately lost his leg. But Nigeria is a complex way where we have some major work to do in Nigeria, because the endovascular climate is not very good. And I've been working hard to improve it, but it's still a challenge.
Wow. Whew. I want to say thank you. I was, looking for when to actually showcase you to talk about what you do in Nigeria. You really don't have to, but you do. A lot of us are going back to go give back. What you are doing is just astronomical because we don't have anything else. And it's not like we don't have capable physicians over there. We need the tools and we need them to work. Right?
Yeah.
Am I right?
Oh, you're right. Yeah, you're right. I like I said, I go to Nigeria every 6 weeks or so, and it's then vascular climate. We're working hard to improve it. Again, you can't have somebody who comes from a remote area and they have no resources to get to Lagos or Abuja, whatever. You have to kind of make ways so they're not traveling from Abuja to Lagos. If they're in the north, they want to come to Abuja. In the Lagos area, Ibadan, whatever, to come to Lagos. If they're in Port Harcourt or Bayelsa, where they can go, make it more regional. So that way, once they have an ischemic problem, be it a stroke. Again, one thing we must know in Nigeria, lots of strokes. And we're talking about from age 30 and above. Again, if you have a stroke, you go to the hospital, they can't do a CT scan, you're toast. You don't know if you have an ischemic stroke or
if it's a clot.
Exactly. So, and that's not a sad event. So the country's rich, but unfortunately our resources are not being applied in a nice manner to make it helpful for all the citizenry so they can enjoy good health. Good health is wealth. And right now it's a problem.
Health is wealth. And, what you're saying, every region needs to have a fully equipped, functioning vascular unit. Dr. Izugu has started doing that in the cardiology area. He actually started in Enugu and now has a branch in Lagos. Dr. Izugu, good. It's on the platform. Go ahead. This is Dr. Izugu, that Dr. Oye, because we need to talk and see how we can do this. It's possible. It is possible. Go ahead, Dr. Izugu.
Yeah, greetings, Dr. Oye. Kudos to you. The issue with Nigeria is we all have to bear it in our heart that we are not in here except for what that country gave us. And so we have to continue to struggle to make things better no matter the odds. And I know it hurts you very bad that somebody have to lose the limb because something you have fixed just like that, in here, and so you find these obstacles that you cannot control, but you have that skill to do those things and do them very quickly and very easily. So all we can just say in this platform, again, kudos to you, and we should all continue to work hard to make life easier, use technology, and really be able to access people remotely wherever they may be and help and train the local people on how to do these things. Because for us, they are very smart. We can train them and then monitor them from anywhere we are. And that's what we are doing with the Heart Disease Prevention and Training Center. So all our sites are training, and we're now, approaching a situation where we can work with them from here. Any staff that can work with us can work with them as well in training them in that process. So we should talk. We should really, really talk, because this is what we do. And, you are in the battle, you are fighting it. And we all want to be doing that very well. Yeah. Congratulations. And thank you for all you do.
Thank you. Nice. Thank you.
Yeah. Dr. Oye, when my mom had an incident and got an EKG done that I could not interpret, and I'm like, I couldn't interpret this EKG. It didn't make sense. So I took a picture, sent it to Dr. Izugu, and he texted me back laughing. No, he called me. He called me back. He was laughing. He said, the leads were placed wrong. Right. So I said, wait a minute, when are you going to start the one in Lagos? He said, we're ready. I said, what are we waiting for? He said, furniture. I said, where do you get the furniture from? From the US. I said, I'm donating every furniture in there. And he did. I said,
I should did.
I'm talking EKG machine with the papers, chairs, desks for patients, for computers, everything. Right. And one of my sisters, Funke Obebe, donated huge printers.
That's exactly right.
And stuff. we furnished the place. We needed to do that. We got to talk. We have to continue. And there are ways to do this and train the people on ground. You go in every 6 weeks, it's your money. It's your, equipments and all of that. We need assistance and we can get them. So we need to chat. We have to continue doing what we're doing. I say thank you so much and kudos. Thank you. Thank you, all of you. Everyone on this platform and more that have been, not only making changes here, but going back home to do the same. May the Lord continue to bless you. Thank you.
Thank God. Thank God.
Thank you. So I have a question here, Dr. Oye. It says, what are the initial symptoms of these disease entities, like the leg pain? You showed us a lot of pictures of people who waited. Can you imagine? Waited that long. Here, as well as in Nigeria, there's no difference.
No.
They have these huge wounds and all of that. What are the symptoms, is the question here.
The typical symptoms of peripheral vascular disease, peripheral arterial disease specifically, are encapsulated in what we call the 5 Ps. So most important that the patient would know is pain. They'll have pain. If they have pain, followed by a cold limb, followed by a pulseless limb, you don't have a rocket scientist, they have an arterial problem. Now, if they have numbness associated with it, then you're asking yourself, is this numbness from the back, or is this numbness because there's no circulation at all? Now, if there's no pulse, then the numbness because there's no blood flow, because blood flow to the nerves are shot. So then that way it'll be numb. So numbness can result in paralysis. If you see a patient with an ischemic leg or painful leg, the most important thing that you as a physician must do to see if it's something that's acute that has that window, because there's something called absolute ischemia and relative ischemia, about 8 hours. If I wake up today and within 8 hours of when I start having leg pain, that's a relative time period. If I seek help and go to a vascular surgeon of choice and they identify to have an arterial problem that wasn't there last night, and they intervene, I have and is successful, my flow will be better. I'll get back to normal. If I see the doctor 8 hours after the event, I'm trending towards absolute ischemia. What tells me as a physician that I have a case of absolute ischemia is you ask the person to wiggle their toes. On one leg, they can wiggle their toes real good. On the other leg, they can barely do this. They have an advanced ischemia. So that person does not have any more time. Time is against that person. You got to make sure you get that person to the vascular surgeon ASAP, because that person needs an operation to restore flow as quickly as possible. Because if you don't, and the doctor even goes back and restores flow, they'll still have a non-functional foot. They have a foot that's there, but it's not working. So they may end up needing an amputation. That's why it's important when somebody comes to us that we make the correct diagnosis, because what mimics arterial flow problems would be sciatica. Oh, the doctor says you have sciatica, when indeed you have no flow, then the patient believes us because, hey, my doctor said I have sciatica. You'll go home and patient goes home and comes back a week later. That happened, to a patient I had seen, went to one hospital, you have sciatica. Patient goes home a week later, the leg is worse, it's cold, it's painful, it's throbbing, there's no flow, it's getting dark. She goes to another ER and she was flown to my hospital. I'm like, whoa, this is not good. 40-year-old lady, it's too bad. This person eventually we did the surgery to restore flow, was good, but she still needed an amputation. So that's essence. So that 8-hour window. But again, that's what the textbook says. I have seen patients 24 hours later, 48 hours later with ischemic leg that's supposed to be absolute ischemia, that we go in and do surgery and still do normally well. So again, it's just a window.
So when you say ischemic leg, just to bring it home, it means there's no oxygen, right? There's no flow. That's what that means.
Yeah, what happens is the body, the muscles of the leg, like the muscles of the brain, like the muscles of the heart, they all need oxygen. When you're oxygen deprived because you have a blockage, or you have blood clot, stopping blood flow to the leg. What happens if you're walking, you have more pain because your muscles have to work. They need oxygen. And the blood carries the oxygen. The blood's not getting there because it's clogged up. It's not reaching your calf muscles. So then you have pain when you walk. And that's why the first manifestation of ischemic leg is pain to the patient. The manifestation that we as the consultants, as the PCPs will be looking for is there a pulse? Is there a pulse? They're good. There's no pulse, very bad. So the pain for the patient, no pulse from the examining physician. It's cold to the patient. It's cold to the consultant also. Then the patient will say, my leg is numb. I feel numb. Then that's advanced because the nerves are getting injured because there's no blood flow to the nerves of the leg. So that's the advanced area. That's the absolute ischemia.
Thank you. So Love said, how can we help by using this platform? Can you unmute and explain that question, please, so we can appropriately answer it?
Hi, good evening, everybody. Is in terms of what you guys talked about, going back home and you need some maybe medical equipment or stuff, helping people. So I don't know if this platform, Medical Mondays, as a form of donation, that we can do either monthly, weekly, or whatever. And we can actually say this is, it's coming from Medical Mondays, because I know there are so many other charity organizations out there, but we want the ones that, there will be accountability and they will use the funds for the right resources. That's why I was asking that. Is there any, do you have any form of donation, or or this is just giving people information? Okay.
There is, but let's get together, these three of us, and discuss, and we'll get back to you. It's a promise. Okay. We always do that. We always get back on Medical Mondays.
Okay.
There is opportunities and abilities to donate, and it is tax-free, so that you can get tax credit also for that donation. Thank you, because what we need is, money to buy equipment, money to pay staff and all that. We've been doing that from our pockets.
Yeah, so it's time, because you guys are giving us a lot of juicy information on medical prevention. So, if we can channel our funds towards this, and it's going to be fulfilling. We have about 50 people online now. So if you guys can come up with something just to show appreciation and to help.
To help. What it is actually, to help. Then it's effective. This is a family, and I have an announcement to make in a few, and you would understand more. Medical Mondays with Dr. O has become a family. Believe it or not, even outside of this forum, we are connecting to do so many things. People connect and do a lot. I just came back from Tampa, from Auntie Tawa's daughter's wedding, Tony's wedding. I precepted her. It's part of Medical Mondays family. I just came back last night. It's a family. And welcome. Welcome. We will get back to you. By the grace of God, we'll meet, we'll discuss and get back to you on how to be part of this. It's not just, funding, you will be part of it. And there is accountability. For the, clinics I just told you that I donated to, we chat all the time. We get almost daily accounts of what is going on, who was in, even when they went to the market, to go educate people so that they can come in for just even preventive care. They've added preventive health care to the cardiac unit. And we got insurance also, that people get insurance and cardiac issues are now covered. That was not there before. Dr. Izugu worked hard to get the federal government to add cardiac issues. to that people, you can buy insurance for your family now for, I think is $50 for a year
Yes.
in Nigeria.
Yes. Yes.
That's part of the work that we've been doing.
That's
That's right. That's
So
right.
it's a lot. We'll update you. What we'll do is we'll have a Medical Mondays where we just discuss what we're doing and how to be part of it. It's not just donating, it's being part of it.
Exactly.
So and you're getting regular updates and can also go to Lagos, Enugu, and we're going to work on the vascular one too. we have to work it together
Definitely.
so that you can go visit.
Yeah.
As one of the people who are making it happen. Yeah. Thank you.
all right. Thank you.
So much. Thank you. So Auntie Tower. Oh, that's my auntie. I just came from Tampa. Just went to, hang out with her. Auntie Tower, you can unmute, ma. Go ahead, ma.
Good evening, everyone. Good evening, Dr. Oye.
I'm surprised you're awake.
I'm forcing myself to be awake. I couldn't. I've been shuttling between airports. I just came back.
Oh, wow.
Thank you for coming. Thank you for everything you did, Dr. O. Everybody is talking about you all over Tampa. Thank you very much.
Thank
And I've
God.
seen some people here at the party that already came in for this
Medical Monday.
Medical Mondays. Yeah, I want to know, is there a relationship between the aortic aneurysm, TIA, all the aneurysms? Is there any connection between every one of them? And the vascular problem with the toes being numb, the sciatic nerve, and every other one. Is there a relationship between every one of them?
Just indirect. I remember the biggest heart driver in the body is the heart. And from the four chambers of the heart. Then from there, if you develop any blood clots in the heart, the clot can go anywhere. It can go to the brain, and go to the arms, legs, or feet. So that's number one. The aorta itself, normal size of the aorta is about the size of a quarter. Once the aorta starts to expand double that size, then you consider that to be an aneurysm. And then when you have an aneurysm sometimes will have blood clots within it, and the blood clots can now escape. If the aneurysm is in the belly area or the chest area, it can escape. When it escapes, if in the chest area, it can push some blood up towards the brain and get a stroke. But if mostly it will go towards, in the belly area, go towards the toes or intestines. And then again, when you talk about numbness, the only time circulation problem will cause numbness if there's total blockage of the artery. Some people have complete blockage of the aorta. When I say complete, 100% blockage of the aorta. Then restarts beyond. So, and those are the people that would do big surgery on. Sometimes will have to do a big bypass, open the belly, move the intestines away, and cut that area out, and so a bypass around that area that's clogged up. Nowadays, with endovascular technology, even with people who have blocked arteries in the aorta, we sometimes can make wires go through it and put stents in, so we don't have to cut them. So that's what it does. Sciatica is a big issue because it mimics lack of circulation. Some people, the pain they have, and the point that the specialists and the ER doctors may even think you have a circulation problem when indeed you have a sciatica. So it's important that any person that comes to you and you suspect a sciatica, that you do a simple back x-ray to make sure they don't have disc problem in the back. They have bulging disc, maybe pressing the nerve, and the nerve now transmits the pain downstream, and they have the pain downstream. So that's an easy fix. Once somebody has leg pain, artery, vein, nerve, muscle, bone, the most important is artery. If the artery is normal, you're not going to lose your leg. If your veins are bad, no big deal, we can fix them. If your muscles are not getting enough circulation, it's good because you don't have blood flow, or it could be because you're taking certain medicines, or maybe some of your electrolytes are off, maybe I have muscle pain. The nerve pain, if your arteries are fine, your veins are fine, your muscles are fine, then then you know, and your bones, you don't have a broken bone, you have a nerve problem. And that's how you know somebody who has a nerve problem versus an arterial problem. And obviously you can do the EMGs and all the other stuff, but if you exclude the artery, that's normal, the vein is normal, muscle is normal, and bone is not broken, you have a nerve problem. So that's the way we discriminate.
Thank you, sir.
Thank you.
So there's a question here that says, is leg cramp related to leg vascular implication? Cramp.
It can. If the circulation is not adequate, some people can get, may get the symptoms of leg cramps as their beginning problem. Again, as the circulation starts to decrease, some people, when they walk, normally when you sit, you don't have a problem. Like we said, when you walk, you need oxygen to feed your muscles. And if there's some blockage of the arteries, when you walk like not too far, you get pain. You stop, you rest, you get more pain when you start walking. That's called intermittent claudication. That does not require surgery. That requires you to take medications such as Pleadol, Salastazole, pentoxifylline, aspirin, dipyridamol, any of those to help you, and exercise and walk. That will increase your collateral circulation. You'll be fine. If you live in Europe, you live in Nigeria, you live in Canada, that's the first step. In America, we tend to be spoiled. You have leg pain, you want something done right away, and they smoke like chimneys, but have leg pain. You go work somebody with smoking problems, and they have circulation problem, and they keep smoking. You do fantastic surgery, they'll get blood clots, and they have more problems to lose a limb. So you should not be in a rush to operate when they don't have to. So they have to do the exercise, walking, medication. Then you do the test and the ABIs and stuff, and the CT angiograms to decide what the problem is and how to fix it. But again, leg pain cramps also could be from electrolytes. Your potassium is low, your calcium is high or low. Those things also give you leg cramps.
Hope your question was answered. Thank you so much. Okay, I send a password. Another question is, what is the feeling in the legs that feels like insect crawling up and down the leg to the foot?
So those people most likely have either a nerve problem and or a vein problem. So if you look at your legs, and most ladies like to look at their legs, they have varicose veins, nice tiny spider veins. If those veins burst, sometimes you have instant stinging sensation. Sometimes you have a crawly feeling. Those are the reticular veins, small veins look like spiders, slightly bigger than spiders. And when they burst, you have that type of sensation. Now, if the veins are huge, like real ropey, large varicose veins, you have more like insufficiency of the valves. The valves don't work well, so you have lots of discomfort. Again, you do a hard day's work. In the evening, your legs feel heavy, like 1,000-pound weight. Because you have varicose vein issues, your veins are not working too well. Those people, when you look at the legs, sometimes the veins block hard veins, and sometimes I need surgery. Okay. Now, one thing I didn't talk about today, which I think I'll be remiss in not talking about it when it comes to veins, is the portion that has to do with DVT, deep venous thrombosis, as well as pulmonary embolism. Those are killers. PE, pulmonary embolus, can be lethal. You could have a blood clot that escapes from the legs, usually in the legs, to the lungs, and it could damage or cause the blood flow interruption in the lung. And if it's major, it can stop the exchange of blood oxygen and can cause death. So PE is the major issue. Nowadays, we have ways of fixing blood clots in the legs. Now, any person in this forum right now, if you have a leg pain and your doctor says you have DVT, if you're less than 80 years old, don't just settle for Eliquis, Xarelto, Coumadin, or aspirin, whatever, as your treatment course. If your leg is swollen and it's confirmed with ultrasound, you have blood clot, you have DVT, ask for a vascular surgeon that can take the clot out. We have techniques that we can use to suck the clot out so it comes out. What happens is if you just leave the clot in the vein and you don't touch it, don't give it any medications, you'll probably get better 2-3 months later. But the damage to the valves, because veins have valves to carry blood back to the heart, the blood clot sits in the valves, it damages your valves. So even if you get better with medical therapy, you may have lifelong swelling of your leg with pain. And if you're young, 30, 40, and you have a DVT that was not adequately or well treated, and was just treated with medication, oral medications, you may end up with what we call a post-phlebitic syndrome. And it can be so debilitating in some people that they become disabled. At 35 years old, you sick for disability because you can't work. You get up, your leg swells, you have pain, you're uncomfortable, you can't go to work, then you get disability. So it's important that your window of opportunity to fix that leg is within the first 1 week of when it occurs. So once you have a swollen leg, and you need to go to your doctor, get an ultrasound. If there's a blood clot, ask for a doctor that will give you medication to suck the clot out, either TPA to lyse the clot, or a catheter that goes and sucks the clot out so you can restore your flow. Now, just taking medication, sometimes you have bad results. You may feel better, but if you're that unlucky person that has the post-phlebitic syndrome, it could be months or years, or sometimes lifestyle limiting completely.
Thank you. Thank you for adding that, DVT. And that is new and cutting edge, because what normally is done is put patients on blood thinners.
Right.
So what you're describing now is new and cutting edge to actually take the clot out. Thank you so much, because I'm going to incorporate that in my practice. For this last question, the leg that is, feels like crawling, insects crawling, you did say it could be a vascular issue. So this person should see a vascular surgeon, or what would you suggest? Yeah.
They can see a vascular surgeon just to make sure that the circulation's okay.
They have good pulses, I believe.
Say it again.
They have good pulses, I believe. So
Yeah, it's probably a nerve problem or probably a vein problem. So you got to make sure they check them out, make sure they don't have reticular vein issues that's bursting, caused a crawling feeling. So usually that crawling feeling is usually a vein problem or a nerve problem.
So it's important to see a vascular surgeon. Got
Yeah.
you. There's another question. A headache that has been on and off for 2 years, and all tests done, MRI, CT scan, all of those showed nothing. They were all normal, but the headache is still there. Comes on and off.
That's make sure it's not tension. Is it tension, headache? Usually the good news is there's nothing pathological wrong, i.e., an aneurysm in the brain, so that's good. But got to make sure there's not tension, headache, lifestyle. Sometimes there's certain things we have. Check your environment, because sometimes you may be living in an environment where you just painted your house, and all of a sudden you have the fumes of the paint that's causing your headaches. Or you may have a place that you may have mold in your house that's caused you to have this headache. So you got to go back and figure out something within your environment that may be triggering your headaches. So you have to look into that a little bit longer. If there's no anatomical reason why you're having a headache, you have to look into your environment. The answer may be there.
Thank you. So how do you explain the difference between PAD and PVD?
PVD is broader.
Let me explain that, because we have audience that are not medical, so this is not fair between.
PAD simply means peripheral arterial disease. So you're specific to the arteries. PVD is interchangeable, but PVD adds vein and arteries together. So if I say peripheral vascular disease, I can be talking about veins and arteries. If I say PAD, I'm only exclusively talking about arteries.
Fantastic. So what about feeling numbness in the left arm once in a while, if pressure is okay or not?
Well, numbness in the arm, if you have numbness in the arm, the very first thing you should do is check your radial pulse. If you have a pulse, then you're good. Then the most likely reason why you have that numbness could be twofold. It could be either you have something in your neck, disc in your neck, pressing the nerve, and therefore having the referred pain down. So you need to have a C-spine X-ray done to make sure you don't have a neck disc issue. Then if you do, then seek your spine surgeon to take a look, because sometimes you may have a pinched nerve in the neck or at the elbow area, all the nerve that may be causing the problem.
Fantastic. So diabetic patient with leg pains that sometimes last for days, the patient noticed that these pains come after a long walk.
Yeah, diabetic neuropathy is kind of interesting, and there are certain things you can do. So there's certain non-medical things you could do. If you're diabetic, if you take yellow mustard, a classic yellow mustard, and just take a tablespoonful of it, it kind of helps your diabetic neuropathy pain. Okay, but if you're not diabetic, it doesn't help you. If you're diabetic and you have the problem you just described, that yellow mustard does help. Vitamin B1 also does help with that. So those are the things I typically recommend for that. In addition to if it's that bad, you can use the gabapentin and things like that. But if you'd want non-medical treatment, yellow mustard and vitamin B1 does help.
How do you eat the yellow mustard? Just with anything, bread or what?
Just lick it, 1 tablespoonful. Yeah, so if they wake up at night, they're having that crampy pain at night, you're diabetic, just take 1 tablespoonful of yellow mustard and lick it. Within 2 minutes, the pain will go away.
Wow. Fantastic. And vitamin B1. Fantastic. Thank you so much. It says, I think to follow up, what do you do? It's the nerve, if it's the nerve. Achepong, I don't understand that question. I'm sorry.
So to follow, thank you, doctor. To follow up with the nerve, in the question about the numbness in the nerve, so what do you do to follow up with the question? What do you do if it is about the pinch, the pinch at your neck?
Spine surgeon. You have to say a spine surgeon. They will do a C-spine of your neck, MRI of your neck, and if they find something significant, for example, you can have a disc that's pressed on the nerve. Sometimes they may have to decompress the nerve, so they will have to go to the neck area and release the nerve pressure, and you'll feel better. So yeah, so you must once you exclude a vascular problem and you nerve problem, then you'll be best in the spine surgeon or the neurosurgeon that does that type surgery.
So if you've done all the therapies and everything that they required, it goes and then it comes back, what do you do?
Well, you still I think you're still best. You have to see that spine specialist. Maybe whoever you're seeing, it's not giving you enough interest, giving the person enough interest. You need to seek for a good spine surgeon somewhere that will listen to you and maybe do the appropriate testing. Sometimes they can do what we'll call an EMG to kind of discriminate exactly where the pain is coming from, and they can isolate it. Again, the spine surgeons do tremendous good work. And now, just like vascular surgery, they now do minimal invasive spine surgery. They don't have to make big cuts. They can, identify the problem with MRIs and go specific to that location and release the nerve that's causing you a problem, and your pain will go away.
Thank you.
Spine surgeon. You probably have been saying orthopedic surgeons. They have spine specialists. That's why I kept saying spine surgeons. So you want a spine surgeon or spine specialist.
Thank you. Thanks.
Welcome. You're welcome. So the mustard, the yellow mustard, there's a question that, is it used for deli? Is it the one used for deli?
Oh yeah, the one that you normally put on your hot dog. Classic, not Dijon, the original American classic mustard.
Ah.
Yeah, the yellow one, not the one you put the French one. No.
Okay, the original
classic mustard. Yes, ma'am.
Okay. Yeah. The original American classic.
Yeah, mustard, yellow mustard.
I left the yellow out. Yellow mustard. Fantastic.
Not Grey Poupon.
And you said vitamin B1, correct?
B1, yeah, 100 milligrams.
Fantastic. So thank you so very much. Look, we appreciate you beyond words.
No worries.
You did say a tablespoon, one tablespoonful, not teaspoon.
There's no restriction. If you have the discomfort, take it. So you're not going to get side effects to it. So yeah.
So what would be your parting words for us tonight?
Health is wealth. Your health is important. You are the architect of your own future, of your health. So you know who you are in your body. Your doctor sees you for 10 minutes. And if you provide the adequate information when you're not feeling well and you're open with your doctor, they're able to come to a more closer diagnosis quicker. But if you go see your doctor and you keep out vital information, it becomes problematic. So when you go visit your doctor, make a list of the things because when you go, you might forget. So make a list of the questions you need to ask your doctor, A, B, C, and D. Just put them so you don't forget. Again, just like you check your blood pressure every day, it's important to check your blood pressure every day because blood pressure is the single most important item you can control that could save your life. It can prevent you from getting strokes, heart attacks, kidney problems, and even circulation problem, PVD or PAD. So controlling your blood pressure. And we know as Africans, generally speaking, our blood pressure is uncontrolled. When I go to Nigeria, you can be talking to a Nigerian person, their blood pressure is 250 over 150, and they look at your car, and that's a problem, okay? So, and next thing you get a stroke, and next thing some bad things happen. So just control your blood pressure because you can avoid strokes, heart attacks, kidney problems by just controlling your blood pressure. Very important. Take cancer out of the equation. Blood pressure is actually a bigger issue than anything else. Again, know your ABIs, ankle brachial index. Next time you go to your doctor, force your doctor to do an ankle brachial index on you. It's the blood pressure of your ankle and your arms. And the ratio, if your blood pressure in the arm is 100 and the legs 100, you do the ratio is 100 of 100 is 1. Okay, if it's bad, if it's 0.8, 0.9, you have mild circulation problem. If it's 0.5 or less, you have severe circulation problems. So you know you have a problem because if your API is 0.5, when you walk, you're going to have pain. You don't have to be a genius. You would have pain. Each time you walk, you have pain. You have to stop. You have to rest because API is low. If your API is normal and you're having pain, then most likely it's either you have a broken bone or a pathological fracture or you have a nerve problem. Very easy. So we don't want to make it too hard or too difficult. It's very easy. Your circulation is normal or abnormal. If it's abnormal, the degree of abnormality of a circulation makes a difference. If degree is less than 0.5%, less than 50%, you will have more symptoms when you walk. You would have to stop more often. You can walk 50 yards. You have to stop the rest. You can't walk 50 feet. You got a problem. Go see your doctor and force them to do the ankle brachial index. And if you do that, again, if you're age 50 and above, make sure you check your carotid arteries, make your carotid artery clean. So you don't want to wake up one day with a stroke and get a stroke and all of a sudden your life changes. If you have a stroke and you don't recover fully, your life changes really. So make sure at some point in your life, when you get 50 and above, get one quick ultrasound of your neck. Make sure it's clean. Get an ultrasound of your belly. Make sure you don't have an aneurysm. Then make sure your ABI is okay. If you have do all those three things, you're good. The other thing that you have to worry is, at some point every 3 years or so, do your colon test. Make sure you don't have colon cancer or whatever, or lung cancer. And you're set. Those are the things that kill us in America. It's the same things that kill people in Africa. But the difference is the per capita income in Nigeria is $365. So but they would rather eat than check their health. So we'll have to go in and help them every so often.
Thank you. Thank you so very much. Dr. Oye, we are grateful. You've given us a mouthful, but not only that, you've given us a challenge to assist in your work in Nigeria. We have to make sure that we get you to be able to go to different regions and be able to deliver care quickly while you're teaching the ones on ground so that we can save limbs and, prevent, cure,
Yep.
those state-of-the-art interventions. Tonight, though, Dr. Oye, my heart is heavy. I was asked by several people if I was going to do Medical Mondays tonight. I was supposed to start clinic at 9 today. I think I got to clinic after 10 with a packed waiting room of patients because AJ, can you bring up the poster, please? One of our very own family members on Medical Mondays died.
Wow.
Dr. Bill Craig.
No way.
Oh,
Yes.
oh God.
Yes. He died of a heart attack.
Mm.
Jesus.
He died of a heart attack, and I found out this morning.
Oh no.
I was trying to send out the Medical Mondays reminder when I saw his wife's email.
Mm.
I was in Tampa with Auntie Tower when somebody texted me and said, "Have you heard of Dr. Bill?" I asked, "What's with Dr. Bill?" And there was no response. So I called his number. It did not, when they called me back, I had muted my phone because I was at an amazing wedding. And I, muted the phone, and so I don't disturb. I saw the call, but thought I would call him when I get back. But this morning, this was what I found.
Wow.
Greg.
Wow. Sorry.
Wow.
Yeah.
Wow.
Sorry. So sorry. That thing's unfortunate, unfortunate.
But if we don't have Medical Mondays tonight, Dr. Bill will be turning over
Right.
because this is what he will want us to do.
Right.
Wow.
Disseminate proper, cogent medical information.
Unfortunate.
Yeah, sorry.
Sorry for the loss.
Please, rest in peace. Yeah. That's one of the things why your program is upgraded. That we continue to expound
Rest in peace.
the rest of the world best we can.
Dr. Oye, can you believe your presentation tonight, your teaching tonight was right on point? On vascular issues, you talked about high blood pressure, preventing heart attack.
Yeah.
Right on point. Please, everything we're hearing, let's take it to heart and prevent in us first. Yeah.
Wow.
If you can please give him a minute of silence. Dr. Oye, I'm going to hand that over to you to help me keep track of that. And a minute of silence, please.
May his soul rest in peace. The Bible says, for the living know that they shall die, but in the dead know not anything. Neither can they partake of anything that's under the moon, star, before the memory of them is forgotten. Therefore, whatever our hands find to do, let us do with all our hearts, because we never know when we'll be going to the grave. So it's not when we die, but what we do between when we're born and when we die, the dash that matters. So I'm pretty sure Dr. Bill and his daughter have done tremendous work in their lifetime, and hope that their souls rest in peace, and also would also their legacy will live on. Thank you.
Amen.
Amen. Wow.
This is so
Amen. Amen. Thank you so
Mhm.
much, Dr. Oye. I'm sure a lot of you on this platform remember our sister Naomi Oye, who also passed earlier this year. We had a
Yeah.
minute of silence for her. Dr. Oye, who presented tonight, is her older brother.
Wow.
Yes.
Wow.
Wow.
Yes.
So